I'm Helen Dakin, a university research lecturer at the Health Economics Research Centre in Oxford. To give you a brief overview of my career, I've been doing research work at HERC for nearly 14 years, having moved from Abacus International. I'm a senior research fellow at the NIHR Biomedical Research Centre. I'm also a module co-lead on the MSc and short course in clinical trials. And I've published more than 58 articles with more than 100 researchers worldwide. These have covered a huge range of disease areas, including musculoskeletal disease, eye disease, diabetes, and paediatrics. I've also worked across a wide variety of different methods. So a lot of what I've done has been model and trial-based economic evaluation. I've also done papers using econometric techniques, predicting determinants of NICE decisions, mapping between quality of life measures, methodological papers looking at methods for health technology assessment, or the types of economic evaluations we should be using. My current projects include using large data sets to explore the epidemiology and predict outcomes for people with diabetes around the world and in Malaysia. I'm also working on the knee arthroplasty trial, which is a randomized trial comparing knee prostheses that's been going for more than 20 years. I'm also involved in the SWEET study on breast cancer and the STAR trial on macular degeneration, and a registry of pre-dementia Alzheimer's disease. I'm also a member of the UK PDS Outcomes Model Steering Group. I developed and continue to update the HERC database of mapping studies, which is widely used for research and for health technology assessment. One particular area of interest of mine is looking at the impact of interactions between health technology assessment decisions. And this is something that Alistair Gray and I published in 2018 and are interested in doing more work. So generally, researchers evaluate one treatment at a time compared with a single comparator. But in practice, there are likely to be interactions between treatments. So for instance, giving statins may change the incremental costs and qualities of blood pressure drugs through reducing cardiovascular risk. Policies for HPV vaccination and cervical cancer drugs may change the cost effectiveness of cervical cancer screening, while second-line treatment decisions may affect the cost-effectiveness of first-line treatment. If we ignore these interactions, we may make the wrong decision and may not maximise health from the healthcare budget. So when there are interactions that could change the conclusions, we may need to use one of several different approaches. We may need to make a simultaneous decision about these interacting interventions, and we may need to compare combinations incrementally. We may need to carefully consider the order in which the interventions are assessed, and we may need to make different recommendations for different subgroups of patients. We also may be necessary to test the impact of changing the assumptions. Thank you very much for listening.